Good evening, everyone.
Good evening.
Good evening. Can you hear me?
Yes, we
Yes, we can hear you.
We can hear you.
Yes, I can hear you.
My name is Suleiman Ademola. I shall be the moderator for this night's presentation. I welcome each and every one of us to this special presentation that will be given by our Professor Valentine Odili. However, before I start, I want to call on one of my brothers, Dr. Solomon, to please give us an opening prayer. Dr. Solomon, are you online?
Yes, I am. I am Dr. Suleiman.
Can you please
there
give
are,
us an opening prayer?
okay. No, wala. If say, but who the God pleases, let him go. I thought there are other Solomons. Maybe it's my own. In Jesus' name.
Amen.
Father, it wouldn't have been possible without your effort today. You are the best we have. And we cannot do it alone without you.
Yes.
You made it possible for us to be here this night. You have been doing it before in the past. And you made a promise that it will be a continuity. As we wait for this lecture to be delivered from one of our finest from the Department of Clinical and Pharmacy Practice, Department, University of Benin, I believe that it will form integral part of our knowledge stream that will make us to reshape our profession to the best in the world and beyond. And we pray that will be a simulator that will connect us much better for the best of this noble profession. We pray in the name of the Father, we pray in the name of the Son, and we pray in the name of the Holy Spirit. Amen.
Amen. Thank you so much. May God accept the prayer, and then may He also increase you in knowledge. Thank you, Dr. Solomon.
Thank you, my brother.
Before I call on the presenter, I want to recognize some of our own. It is our duty to always recognize them so that the world can as well recognize them. I will start with no other person but our national chairman, FIPAN, Dr. Joseph Madu, the fellow of Pharmaceutical Society of Nigeria and the fellow of the Postgraduate College of Pharmacy. I also want to recognize the National Secretary, Dr. Mutihat Buki Olu Lawal, the fellow of the Postgraduate College of Pharmacists. I want to recognize as well the chairman of the pool of experts, Dr. Ole Joseph, as well as all the members of the pool of experts. And I also want to recognize the members of the CPAN Education Committee, the members of the CPAN Diaspora, members, all fellows of postgraduate or College of Pharmacists, and also want to recognize all the fellows of the Pharmaceutical Society of Nigeria. So, and I also want to recognize each and every one of us in our respective capacity. I want to tender an apology that I have not been saying specific names, but as we go on, I shall be calling specific people as they deserved to be recognized. Let me quickly go into the owner of today, as in the one that holds the floor, and that is the presenter. He is no other person than our own. He owns Bachelor of Pharmacy and MPharm, PharmD, and he has a PhD as well. He is a fellow of the Postgraduate College of Pharmacists and a member of the Pharmaceutical Society of Nigeria. He is a teacher, a mentor, and also a researcher. He has taught PharmD conversion for over 17 years. He has also been the coordinator of the same PharmD conversion for almost 8 years. He has also been an editor, Edo State Pharmaceutical Society of Nigeria magazine, as well as the editor, the Journal of Science and Practice. he has participated in the peer review for both international and local journals, and he is presently the head of the Department of Clinical Pharmacy and the Pharmacy Practice from the Great University of Benin. And he has published over 60 papers. He has supervised many undergraduate students, postgraduate students, as well as 4 PhD students. He is a lover of the profession pharmacy. He loves people irrespective of who you are, and he is also a God-fearing person. Today, we shall be looking at the topic as you have seen it, the kidney disease. We will consider the basis and the review of it. I am going to give our professor the floor for him to do justice to the topic. Sir, you have the floor.
All right, thank you very much. Good evening, everybody.
Good evening, sir.
Great. Okay, so good evening. Thank you very much. Well, I'm no longer the head of the Department of Clinical Pharmacy. I was the head of the department. We have a new one now. So today, well, let me just start by saying that I'm happy to be here today, and it's good to hear from you guys and to see some of you. Okay, so the topic today is kidney disease, basics and overview. So we just want to look at the kidney disease and then look at the very basic physiology of the kidney and how it applies to pharmacists, because for you to make an input in the care of patients that have kidney disease, you need to understand the very basics. And that is what we're going to try to discuss today. So at the end of this discussion, we should be able to describe the renal system. We should be able to enumerate the functions of the kidney, discuss biochemical tests which are done to assess function of the kidney, discuss the abnormalities in biochemical tests associated with renal impairment. And then, of course, we need to understand the estimated GFR and urinary albumin creatinine ratio as the basis of assessing kidney function, kidney damage, and diagnosing and monitoring kidney disease. Now, all these things form the basis of the kidney management. So as pharmacists, we need to understand them, be grounded in them, because actually these are the things that will determine your inputs. I mean, how you're able to contribute to the management of chronic kidney disease. You have to understand how the kidney works, how it functions, and then how the dysfunction of the kidney can lead to pathologies, and then also how to remedy them. So that's what we're going to do this evening. And then if we have some time, we're going to look at the role of the pharmacist in CKD management. So please, can you hear me? I need some response to know that. Can you hear me? Can you hear me?
Yes, you can hear you.
Okay, thank you. My network is not so strong, so I have to put off the video so that I could stream well. All right, so
Yes, we can.
First and foremost, okay, beautiful. So let's look at the renal system. The renal system actually is also called the genitourinary system. It's made up of the kidneys, two kidneys, and then that are connected to 2 ureters, which also lead to the bladder and then the urethra. Okay, this is the genitourinary system, or what we'll also call the renal system. Okay, and this system is what gives the kidney its function. And we're going to look at all this to be able to help us understand how the kidney works and then what happens when there's a dysfunction. So we're going to look at a bit of anatomy of the kidney, a clear view of what the kidney is, all right? So like I said, the urinary system or genitourinary system is made up of the kidneys and the collecting system, which will be the ureters, the bladder, and then the urethra. So each kidney is actually the size of a fist, a human fist. So if you clench your fist, that will give you an idea of the size of the kidney. So, well, of course, everybody has different size of fist. You can also expect that the kidney, on the average, will be the size of a human fist, though some are smaller, but that is the size of the average kidney, okay? And the kidney actually measures 12 by 6 by 3 centimeters. So what that would mean that the length of a kidney could be as long as 12 centimeters, and then 6 centimeters wide, and then 3 centimeters thick. Okay, that gives you an idea of the size of the kidney. And each kidney weighs about 150 grams, 150 grams, okay? And so that shows you how big each kidney is, all right? The kidneys are highly perfused. In fact, about 20% of blood flows to the kidney. Now you might think just 20%, that's actually quite a large amount of perfusion for an organ as small as the kidney. And the blood perfusion is because of the function which the kidney does. The kidney actually filters blood, okay? And in a day, as much as about 180 liters of blood goes through the kidney. Now we're going to discuss that a little more later, all right? So, and the perfusion is because the kidney does the work of filtering the plasma, all right, to maintain the contents of the blood, okay? Now, to give you an idea of the location, a visual idea of the location of the kidneys, if you want to assess the kidney via the abdomen, right, you have to tear off the abdomen, take out the intestines, the large intestine, the stomach, all right, and then go into the abdominal wall. The kidneys will just be resting in the posterior wall of the abdomen. Okay, so it's said to be retroperitoneal in location, all right, so way behind over there, all right, and then in between the spine, the vertebrae, that's where you will find the kidney. So the kidneys are actually located way back towards the back of the body, all right, that's where the kidneys are located. Now, the right kidney is a little bit displaced downwards compared to the left. Well, if you see it in diagrams like this, as though they are the same side, kind of, or the same position, but this right kidney is displaced a little downwards. And the reason for that is that the liver, which is actually a large organ, okay, parts of it rest upon the right kidney, and so it displaces the kidney, the right kidney, down, all right? And like I said before, each kidney weighs about 150 grams, okay? And so that's a way of visualizing the location of the kidney in the body. Okay, so now the kidneys actually, what they do basically initially is to filter blood, okay, or filter plasma, and then the ultrafiltrate, okay, goes to the pelvis and then to the ureter and the bladder, which is more like a storage for urine, okay, or the ultrafiltrate before it goes through the urethra. Now, let's look at the nephron. I'm sure from undergraduate physiology, you've heard about the nephron being the unit of the function of the kidney, and that's correct. The kidney has so many nephrons, quite a lot of nephrons. So this is a schematic of a diagram of the nephron, okay? And there's so many of this in each kidney. So about 1 million, each kidney contains about 1 million of these nephrons, okay, which do the work of filtering the plasma, all right? And each nephron is connected together through the collecting duct. So each nephron has a link to a collecting duct, which also connects to other bigger ducts, which eventually collects to the pelvis, and then it will drain into the ureters and into the bladder. So this is just one of the numerous nephrons that you find in each kidney. Okay, so we say that each kidney is made up of approximately 1 million functioning units called nephrons, all right? And then in the nephron, you find the glomerulus, all right? And you have the afferent arteriole, the efferent arteriole, right? And then this is a capillary bed, which actually, is enmeshed around the uriniferous tubules, okay, where there's an exchange of water and ions, okay, back and forth like that, okay, from the renal vein to the tubules, and the ultrafiltrate goes from the glomerulus through, okay? So that is what actually happens in the nephron. And the beautiful thing about the kidney is that, it has a very high capacity to function, to do its function. And that's because there's so many nephrons. And that's also a problem because a person can actually be suffering from chronic kidney disease and not know it, because once you begin to lose the nephrons, it still functions. I mean, the kidney is still functioning. You still have filtration of blood and all that. And there's no symptom, there's no sign. And so there's no way of telling that the patient is actually losing kidney function because there's so many nephrons. And when some are dying, others are actually working, okay? And until the person gets to the point where the kidney disease advances, you may not see any kidney dysfunction or any symptoms of kidney dysfunction, which is the problem. And that's some of the things we're going to address today as pharmacists. So remember, this is just a unit in the kidney, nephron, and there are very many of these. The glomerulus, where the filtration actually takes place, and the ultrafiltrate goes through the tubules, okay? And then eventually into the collecting duct, which goes into the pelvis, and then into the ureters, bladder, and urethra, okay? So now, the vascular supply to the nephron is a bit complex. Why do I say it's complex? Well, the blood vessels that supply the kidney are not like the regular blood vessels that you have, okay? They are called arteriolar capillaries. What that means is that these blood vessels has the afferent arteriole and the efferent arteriole. I just show you. So this is the afferent arteriole, and this is the efferent arteriole. The afferent arteriole is where blood supplies to the glomerulus. Now, these arterioles are not just regular blood vessels. They're actually called arteriolar capillaries. And the reason for that is that they have a muscular layer, right, which can actually change the tone, okay, tone of the afferent arteriole and the tone of the efferent arteriole. In other words, so this can be dilated and this can be constricted depending on the need, all right? And that affects the pressure of filtration in the glomerulus. That is a wonderful and interesting aspect of the kidney nephrons. Okay, and this becomes important. We're going to also discuss this later on. I will tell you why that is important as we go on. So, yeah, so the afferent arteriole and the efferent arteriole, they can have varying tones, okay? And like I said before, that is to maintain the filtration pressure. And sometimes too, this in itself can also be an adaptive mechanism to help the kidney when it's actually supposed to be failing, because it can maintain filtration pressure and do its function even when the kidney is supposed to fail, all right? Now, this also becomes important when we're looking at certain medications like angiotensin converting enzyme inhibitors and the ARBs. What they do is that they actually cause a relaxation of the efferent arteriole, okay? So for instance, if we have a situation where there's so much pressure build up here and the patient is given ACI, for instance, this efferent arteriole will be dilated by the ACI, and that will eventually reduce the pressure, okay, in the glomerulus, okay? And that is the basis for which the ACIs have renal protective ability or capacity, because they can actually dilate the efferent arteriole and cause a reduction in pressure here. But there's also a negative side to this, which we'll also look at later on, all right? So this is important for us to know as pharmacists, that patients who are having chronic kidney disease or who have risk factors for chronic kidney disease like diabetes and hypertension, all right? These are some of the drugs which can be given to them to help them, okay, preserve the renal function. So that is important for us to know as pharmacists. Okay, now the efferent arteriole exits the glomerulus and forms an arteriovenous capillary bed which surrounds the tubules. So you have this meshwork of capillaries, okay, around the tubules, okay, so much so that there's exchange, okay, of substances into the blood and out of the blood as the ultrafiltrate goes through the tubules. Okay, now much of the water which is filtered in the glomerulus is reabsorbed and returns to the vascular system through this capillary bed that surrounds the tubules. So what we're saying, this capillary bed, okay, surrounds the tubules. So as the ultrafiltrate goes through the tubules, you know, water is reabsorbed back into the blood, okay, and certain substances are secreted into the tubules, while some other substances are reabsorbed back into the blood. And this is because there's a network of capillaries surrounding the uriniferous tubules, which helps in the maintenance of the internal environment of the blood. Okay, so now let's look at the functions of the kidney. Without being told, of course, we know that the kidney does the work of filtration, right? And so most people see the kidney as a filter, you know, and that's what it does. Of course, yes, the work of filtration is one of the major functions of the kidney, but that's not actually how the kidney should be visualized or should be seen, all right? The kidney is not just a filter. If you see it as a filter, that is just a simple way of looking at it. But the kidney actually is an organ that tries to maintain the internal environment of the blood. Is a homeostatic organ, all right? So it's an organ that tries to maintain the solids that you should have in the blood. So the kidney would filter the blood so as to conserve the required solids and water in the blood, and then also discard waste and solids that are not required in the blood. So all the filtration, all the reabsorption, all the secretion that you find going on in the nephron is just because you want to try and get rid of certain harmful substances from the body, and also to conserve important substances that you require in the blood. And we're going to look at all these things as we go on. Okay. Now let us take a closer look at the glomerulus. Okay, so this portion that you're seeing, this is the glomerulus, right? And you have the afferent arteriole again, and the efferent arteriole. You see, blood goes through this, and now we're seeing the inside of the glomerulus. This is magnified to see what actually happens here. All right, and you have this bed, okay, this capillary bed as well in the glomerulus, and this capillary bed is very, very fine capillaries, and they have a semi-permeable membrane, all right? And this semi-permeable membrane is such that it allows certain substances to be filtered through and other substances to be retained. So there's a charge wall, you know, it's a charge wall. So certain substances, for instance, negatively charged substances can't pass through, all right? And then large molecular substances can't also pass through, okay? But small solutes and positive charged solutes can go through and then get into the tubules. So this is what the glomerulus will look like, and this is what happens. So it has semi-permeable membranes, okay? And it's leaky for some kind of substances, but also prevents other substances from passing through. That is how it conserves the solutes that you require in the body back into the blood, not passing through. Okay, and even those that come through, those ions that go through, can also be reabsorbed back into the capillary bed to conserve what is required in the blood. Now let's even look deeper and look at one part of the glomerulus. So this is what you have, okay, part of the capillaries in the glomerulus. You can see that there are these large moieties, these large solutes can't go through, right? But the small positive solutes, okay, or ions can go through. You see that? And then there's some small negative ones too that can't go through. This is how the glomerulus maintains the filtration and maintains ions in the blood. Okay, all right. So filtration of the plasma by the glomeruli. The volume of ultrafiltrate is approximately 135 to 180 liters per day. That shows how much work the kidneys do. Okay, so they filter 180 liters of ultrafiltrate per day. So blood goes through continuously. Now, if you factor in the fact that the human body has about 5 liters of blood, and then you're having 180 liters being filtered per day, it means that the blood goes through the kidneys like 35 times in a day. All the blood in your body goes through the kidney like 5 times in a day. So the kidney is always doing that work of filtering the blood to get rid of substances and forming urine. Okay, and that will give you about 1 to 1.5 liters of urine excreted per day. So the kidney does an awesome job of filtering the blood. So you can expect what will happen if that function is lost and the body can't get rid of substances, and cause that leads to what we find in end-stage chronic kidney disease. All right. So the ultrafiltrate is modified by the tubules, like we said before. All right, and its content is based on what is reabsorbed or secreted. What is reabsorbed or secreted from the tubules. This in turn regulates the content of the plasma. That is why we say that the kidney is not just a filter, okay, but it's an organ that tries to maintain the content of plasma so that the body can function optimally. All right, it's not just a filter. All right, and there's so many intricate things that happen to ensure that happens. Okay, so now let's look at the ultrafiltrate modification. So again, here is the glomerulus, right? The afferent arteriole and the efferent arteriole. So blood comes in through here, right? And then it's filtered, and the ultrafiltrate goes through the tubules, right? But as it comes out through the tubules, even if solids have already been filtered out of the plasma, even as the solids goes through the tubules, there is also reabsorption of some of the solids that have actually been filtered. Now, the nephron, the tubules about 6 centimeters long. So as the ultrafiltrate is going through, there's modification to it. It's not exactly everything that is filtered that goes and becomes urine. You know, there's reabsorption, like sodium particularly is reabsorbed from different segments of the nephron. So we have the proximal convoluted tubule. Okay, you have the descending arm, you have the ascending arm of the loop of Henle, all right, and then you have the distal convoluted tubule, and then the collecting portion. Now, as the urine or the filtrate, okay, goes through this, there's a change in the constituent of the urine, okay, and as sodium is reabsorbed and there's organic acids being secreted, okay, and potassium too can be reabsorbed and all that in different portions. Interestingly, as pharmacists, of course, we know that one of the medications that affect the kidney is diuretics. You know, diuretics help, okay, to remove fluids, okay, from the body, and the different effects of diuretics that you have are based on the portion of the loop or the loop of Henle that the tubules rather that they act on. Okay, so different diuretics will have their different effects based on the portion of the tubules that they act upon. For instance, the proximal convoluted tubule, we have the carbonic anhydrase inhibitors, all right, which are known as mild diuretics. And the reason for that is that here they will inhibit reabsorption of sodium. Incidentally, most of the diuretics, their action is based on the prevention or inhibition of reabsorption of sodium in the urinary tubules. So the carbonic anhydrase inhibitors, for instance, would inhibit the absorption of sodium, bicarbonate, and maybe hydrogen ions from the proximal tubules, you know, and what that means is that sodium accumulates, right? And when sodium increases, what happens is that it will also attract water, and then there will be increased diuresis. But the reason why the carbonic anhydrase inhibitors are known as mild diuretics is because they act here and they prevent the reabsorption of sodium. But you see, as the ultrafiltrate goes down, even the sodium that has been prevented eventually gets reabsorbed at other aspects. And so that reduces the action of the carbonic anhydrase inhibitors. All right. So based on the portion of this tubule that the diuretics act upon, that's what will determine the kind of effect they're going to have. Okay. For instance, now the loop diuretics, furosemide, for instance, acts on this ascending portion of the thick portion of the loop of Henle. Okay. And others can also act on different portions, and that determines how potent their actions are. Okay. So this gives us an idea of the use of the physiology of the kidney in designing drugs and their activity. Okay, so now let's get into the crux of the matter. How does chronic kidney disease happen? Now we have actually looked at the kidney. We understand the kidney, what it does, right? Now part of its functions. Okay, so what will cause chronic kidney disease? Obviously, if anything that affects the nephrons, affects the functioning of the kidneys. All right, and one of the major functions of the kidney is to filter plasma. Okay, so when the kidney is unable to perform its function of filtration, then you begin to talk about the person having kidney disease, right? Now, the effect of declining kidney function is not always noticeable. I already mentioned that. And the reason for that is that there's so many nephrons. The kidney has a very high reserve capacity. In other words, the kidney has a larger than normal capacity to perform its function. It has so much resources to do it. Okay, and so even when you're beginning to lose the function of nephrons, okay, it's not noticeable. The person just carries on as if nothing is happening because there are no signs and no symptoms, because there are large numbers of nephrons doing the work, okay, to compensate for the ones that have been lost. Okay, so usually is when the disease is advanced that you begin to notice signs and symptoms, by which time the kidney, the large number of kidney nephrons actually rather have been lost, which is a problem. And that is why as pharmacists, we need to understand this, and particularly of patients who are at risk, we need to counsel them and also help in their management by asking for them to be screened for kidney function. It is important, and that is the basis of this discussion, so that as pharmacists, we understand how the kidney works, okay, and people who are at risk, how they need to be educated, and how we also need to follow them up when they're taking medication to check how they are doing, okay, kidney-wise, okay? So that's how CKD happens. We said that is because there's decline in the nephron, in the function of the nephron. Of course, yes, sometimes you also have problems in the glomerulus, okay? That can also be a problem too, that can lead to chronic kidney disease. But ultimately, it is because the nephrons don't do their work anymore. That is why you have chronic kidney disease. So that is how it actually has the etiology of chronic kidney disease. Okay, now we've looked at the kidney as a filter, but I dare say the kidney is not just doesn't just function as a filter. There are also other functions of the kidney. And if you understand the function of the kidney, it will also help you to understand what happens when there's kidney dysfunction. So we'll look at the other, or take a closer look at the functions of the kidney. So one of the other functions of the kidney is that of volume control. Volume control, the control of the amount of fluid in the blood, volume of the blood, okay? So this is very important. Like I said before, the kidney is a homeostatic organ, all right? Tries to maintain blood volume, okay? And maintaining blood volume also means that it regulates blood pressure, because of course, the volume is a component of blood pressure, all right? So the kidney can help to regulate blood pressure by regulating blood volume. Okay, so when the volume of the blood is too much, it can reduce it by reducing the amount of fluid or water that is reabsorbed, and until that is excreted and maintains the volume of the blood. Also, the kidney helps to concentrate ions. Okay, it helps to concentrate ions in the blood. Now, the blood requires certain ions for it to function optimally. All right, and the kidney is the organ that does that. So it helps to concentrate, for instance, sodium, potassium, magnesium, chloride, hydrogen bicarbonate, and other ions like calcium. Okay, the kidney does that to maintain the level of these ions. Okay, in the blood. And so whenever the levels begin to rise, the kidney will reduce it, will excrete them. And when there are toxic substances too, of course, the kidney is what removes them from the blood. Another function of the kidney is to maintain pH. We talk about long-term acid-base balance. The kidney does that, maintains the pH of the blood. And it does that by regulating the hydrogen ions and bicarbonate ions, okay? So it can reabsorb, okay, allow the ones that want to be filtered to maintain that delicate balance of the pH of the blood between 7.35 to 7.45, pH of the blood. Another function of the kidney is that of metabolism. All right. Now, the kidney also produces gluconeogenesis when there's a need for glucose to be produced from non-glucose moiety. The kidney can help in doing that. Okay. There's also glycogenesis. So the kidney also helps to store some glycogen. All right. And then the kidney forms vitamin D, helps to form vitamin D. The last stage of the formation of vitamin D occurs in the kidney. And vitamin D is what also helps the body to produce calcium, okay, in the blood. So you see that the kidney is very helpful in this matter. Of course, the kidney also is involved in drug metabolism. Okay, certain drugs, particularly water-soluble drugs, are metabolized in the kidney. Okay, another function of the kidney is that of excretion. We already know that. Okay, so toxins, harmful toxins in the blood are removed. Okay, particularly talking about urea, nitrogenous substances in the blood that come from breakdown of protein and amino acids and protein and stuff like that are all excreted via the kidney. All right, creatinine too is also excreted, and then water-soluble drugs are excreted. Drugs are also excreted in the blood. So the kidney is an excretory organ, and then is also an endocrine organ in the sense that the kidney also produces some substances, okay? Like renin. Renin is the substance that is produced by the kidney, which helps to retain sodium and chloride, all right? That also affects the volume of the blood, that can help to regulate blood pressure. The kidney also produces erythropoietin. Erythropoietin is useful in red blood cell formation, okay? And the kidney produces that. Now, the kidney is not the only organ that produces erythropoietin. I think the liver also does that, okay? The liver, but the kidney produces erythropoietin. Erythropoietin helps in the production of red blood cells, okay? So you can see that the kidney has a lot of functions in the body, apart from just filtering. And if you understand these functions, okay, it will help you to understand what happens when a person, for instance, is having chronic kidney dysfunction. Okay, all right, and you see the things that will happen as we go on. Okay, so decline in number of functioning nephrons. Okay, so even when a large number of nephrons are lost, it's important to note that urine volume may not change until kidney function is almost completely gone. All right, this is very interesting in the sense that you will think, okay, well, kidney function, because the kidney filters, so when there's a kidney dysfunction, then the amount of urine formed will be reduced. That is not always the case, okay? That's not always the case. The urine function can be normal, okay? Because even if the filtration, okay, has reduced, the amount of water reabsorbed, all right, may not differ too much. And so you will still have the actual volume of urine, that 1 to 1.5 liters of urine. Okay, so that may not be a very good yardstick to determine if a person has chronic kidney disease. All right, and the reason for that is that reabsorption of water. Okay, it's the water may not be reabsorbed as maximally as it should. Okay, in some cases when there's chronic kidney disease, and so you still have the volume of urine that the person normally makes. Okay, now people with kidney disease are at risk of anemia. Of course, we know that now because we know that the kidney helps in production of erythropoietin. Okay, so when there's a dysfunction, all right, you expect that there's anemia, and also bone conditions. All right, the person probably has a higher risk of bone breakage. Why is that? Because the kidney helps in the production of vitamin D, right? Vitamin D, and vitamin D helps in the production of calcium in the blood. And so when there's a problem with the kidney, vitamin D will not be produced as it should, and that ultimately affects calcium, which affects the bone formation. All right, and also people who have kidney dysfunction will require dose reduction of some medications or medication change, obviously, because I mean, if some drugs, is metabolized by the kidney and the kidney is not able to metabolize it, and you give that same drug, it means that the blood level of that drug, the half-life of that drug will increase, okay, and that can lead to adverse drug reactions, okay? So insulin, for instance, okay, is metabolized by the kidney, so also is glucagon. So people that have diabetes and also have kidney disease, you should be careful as to the amount of insulin that you dose them with compared to when they didn't have that, okay? Then also, when the nephrons don't function as they should, you have reduced renal clearance, and you can also have insulin resistance occurring, okay? So these are some of the things that happen when the nephrons begin to lose their capacity to function. Next, we're going to look at glomerular injury. Okay, now not the tubules now, looking at the glomerulus itself. Now, glomerular disease is the most common type of kidney disease. And as the disease progresses, the network of capillaries called vascular tuft is replaced by scar tissue and function is lost. Now, the vascular tuft is what I showed you before in the glomerular, those fine capillaries, okay, that have semi-permeable membranes, okay? When they are disturbed or when they are broken down, okay, or affected negatively by maybe high amount of proteins or solutes, they scar, okay? And so when there's scarring, it means it's toughened, it's thickened, and then you cannot have the semi-permeability of the tuft of the nephron of the glomerula, anymore. And so you have a problem with filtration. That's what happens. Okay, so we need to protect that, okay, before it affects all the nephrons, and then you'll be able to have any function. Okay, so damage to the filter allows large molecular weight substances such as albumin into the ultrafiltrate. Ordinarily, proteins are large molecules. Proteins are like albumin, for instance, is negatively charged and ordinarily should not pass through the glomerulus. Okay, it shouldn't pass through the vascular tuft. All right, just a little may seep through, but normally it shouldn't be there at all. Okay, so when you begin to see albumin, okay, in urine, okay, in large quantities, that tells you that there's a problem in the glomerulus. Okay, that the capillaries are beginning to scar, okay, and are not functioning as they ought, okay? So that can be a marker for chronic kidney disease, all right? Now, increased urine protein may be a cause as well as a sign of kidney injury, all right? Yes, so when protein or albumin is the, as it were, we use albumin as the marker for proteins, okay? There are different proteins, but albumin, okay, has been standardized, has been measured, okay, and used as a marker for chronic kidney disease, all right? So urine protein itself can be a problem. That is why people with chronic kidney disease are also told, educated, counseled not to reduce the amount of protein, dietary protein, okay, because the protein actually can overwhelm the glomerulus, the remaining nephrons available, okay, they can cause kidney disease to progress even faster, okay? So the amount of albumin in the urine can be evidence to show that there is chronic kidney damage or disease going on, okay? Okay, so next, let's just digress a bit and look at risk factors for chronic kidney disease. So we have, of course, hypertension. You know, any disease actually that will affect the blood vessels, particularly tiny blood vessels, can actually cause chronic kidney disease. All right, we know that hypertension, you know, can cause end organ damage. Okay, so then also family history of kidney disease. Some people are prone to having kidney disease. It's hereditary, so that can be a risk factor. All right, diabetes as well too, you know, can also affect blood vessels, and so can be a risk factor for chronic kidney disease. Obesity, cardiovascular disease, acute kidney injury, and diet. You know, all these things can cause chronic kidney disease. So people who already have chronic kidney disease, you need to, and they have hypertension and diabetes and all these other conditions, you know, you need to manage them very carefully because they run a higher risk of the chronic kidney disease progressing. All right. Now for nutrition, of course, you know, you have to restrict sodium, potassium, and phosphorus and stuff like that, because of course protein too, because that can also increase the progression of the disease. So what is chronic kidney disease? Now, chronic kidney disease can be defined based on two parameters. One, reduced kidney function. We've seen the function of the kidney majorly has to do with filtration. So when filtration, glomerular filtration is reduced, okay, that could mean that the person is having chronic kidney problems, a disease, okay, there's a dysfunction. So it's defined based on reduced kidney function and or kidney damage, okay? So you can have chronic kidney disease even if there's no kidney damage, but there is reduced kidney function as per glomerular filtration rates, okay? So with regard to kidney function, when the glomerular filtration rate is less than 16 mL per minute per 1.73 meters squared for 3 months or more, okay, we say the person probably has chronic kidney disease. And this can happen with or without kidney damage, okay? And also, if the person now has kidney damage, and how do you determine kidney damage? We'll see that much later on, but kidney damage can be determined based on pathological abnormalities, okay? And how do you note this? This can be done through imaging, all right? Scan, do a scan of the abdominal scan, a pelvic scan, and you can tell whether there's a problem with the kidney, whether there are pathologies, okay? For instance, nephrolithiasis, kidney stones, and stuff like that can be evident when a scan is done, and that can help to show that there's kidney damage going on. But the major marker that can also be used to evidence kidney damage is proteinuria, okay? And albuminuria, albumin in the urine is a major marker, and that can be used. Ordinarily, you should have only trace, if anything at all. You shouldn't really have albumin in the urine. But when that is in the urine, that shows that there's evidence that the nephrons, the glomerular is compromised, okay, and it's not doing its work as it ought, which means that there's kidney damage, okay? And then there's something which we're going to discuss later, the urine, albumin, creatinine ratio, okay? This can be used as a marker, okay, to show whether there's kidney damage going on. Now, there's a whole gamut of tests that can be requested that can help to check or diagnose and to confirm whether there's chronic kidney disease going on in a person, which we're going to look at next. Sorry, can I get a response? Are we together?
Yes, sir, obviously.
Okay,
We're enjoying it.
Okay, thank you. I'm just hearing myself talk, so I'm wondering if there's somebody on the other side. Okay, fine. So now let's look at the kidney function test. Now, I'm sure every pharmacist who has worked in a hospital or who has worked in a community pharmacy and seen test results, okay, of electrolyte, urea, and creatinine will know these tests we're looking at now, okay? And these are the different kidney function tests. These are the different tests to help to check the function of the kidney. And it's based on the fact that the kidney is a homeostatic organ, all right? The kidney actually is supposed to maintain these ions, okay, these electrolytes in the blood, okay? And also exclude them from the urine. And so when you begin to see them, yes, somebody's hand is raised. Hello? Somebody's hand is raised. Hello?
Can you go on, sir? Don't worry, sir. Can you go on?
Okay, fine. All right. So, like I said, this is one of the tests that will be ordered for somebody who is suspected to have chronic kidney disease or somebody who is being treated, and the therapy is being monitored. These are the ways to determine whether the disease is progressing or be able to diagnose the disease. And as pharmacists, we need to understand the basis for this, okay? And that's why we started from where we did, okay, to look at the different functions of the kidney, all right? And because it's the function of the kidney that will help us determine whether the kidney is compromised or is failing or not, all right? So, like I said before, usually the doctor will order for E and U creatinine, electrolytes, urea, and creatinine test. Will order for a full blood count, all right, and certain other. Then of course, you know, the GFR, EGFR, and all that will be reported. All this will help to determine whether there is kidney damage going on and also the function of the kidney. So we're going to look at that. So you see, we have serum urea, okay, this is the normal that should be in the blood, okay. When there's kidney dysfunction, it will increase, okay, because it's not being filtered as it should, all right. Serum creatinine too will also increase. Serum uric acid will increase, okay. Total protein in the blood will begin to decrease. Why? Because ordinarily protein should not really pass through, should not be cleared, all right. But when there's dysfunction, protein begins to pass through, and so total protein in the blood will decrease. Serum albumin too will decrease, all right. So these are the ways that kidney dysfunction and damage can be assessed, right? Then we have electrolytes. Again, I said the kidney is supposed to maintain the electrolytes at a particular level, okay? And so when you see a change, okay, it could mean that there is a problem with the filter or filtration of the plasma in the kidney, which suggests chronic kidney disease, okay, which may suggest chronic kidney disease. So you have sodium is decreased, all right, because you see that sodium is always mostly reabsorbed from the tubules, okay? And so when there's a problem, that reabsorption is not optimal. And so you have decrease in sodium, there's an increase in potassium, increase in chloride, phosphate is increased, and calcium is decreased. Of course, you know why calcium will be decreased, because we said that the kidney helps produce vitamin D, which is supposed to produce calcium. So if the kidney is not functioning because it's damaged, it means vitamin D will not be produced, and so calcium will begin to decline. All right, so these are the different tests ordered, and you can tell if there's a problem with the kidney based on this. Now, for uric acid actually increases, but it doesn't really go very high when there's kidney dysfunction. So when it becomes very high, it is a very, very negative prognostic marker. In other words, when the uric acid is very high in the blood, it shows that the kidney is far gone. All right. So normally there's slight increase in uric acid, okay, even when you don't have severe kidney damage. All right. But when it begins to go very high, you see that it's very, very high, then you know there's a problem, and this has an ominous prognosis. Okay. Then also, of course, you can guess for the full blood count, okay, when there's decrease in hemoglobin and total red blood cell, okay, that shows that there's a problem. That can also show that there's a problem with the kidney because, like I said, kidney produces erythropoietin, okay, which actually helps to produce red blood cells. Okay, so when the red blood cell indices decrease, okay, then it's also maybe an indication coupled with the others that we've looked at that there's kidney dysfunction. All right, the ESR, okay, erythrocyte sedimentation rates can be elevated. Okay, and all this put together, okay, together with the EGFR, okay, and albumin can indicate that there is kidney dysfunction or kidney damage going on. So as pharmacists, we need to understand these tests. So whenever you see E and U and creatinine, okay, you know what it is for and how to actually assess it to see what is happening. You always have the standards, and then you can check what the patient's results are, and then you can tell and see what the problem is. And then even when the patient is now being treated with, when these tests are ordered again, you can compare and see whether the kidney disease has been, the progression has been reduced and all that. So that is the essence of knowing about these values. Now, these values, they come with the test results and they're available. So you can just understand how they're supposed to be in normal, and then what's maybe happening when it's abnormal. That's the essence of that. Then, of course, urine analysis, the color, the pH, specific gravity, analytes. You're not supposed to see protein in urine, right? And glucose too shouldn't be there ordinarily. Ketones and all the rest. So when these things are seen in the urine, that tells you that there's a problem, okay, with the kidney. Now, for diabetes, when glucose is seen in the urine, is because it has gone beyond the renal threshold. Okay, so it cannot stop it from being filtered anymore. That's why it spills into the tubules. So there's a problem. When there's high glucose, it means that, of course, there's hyperglycemia going on, and it also means that the patient is also having chronic kidney problems. Okay, microscopy, red blood cells shouldn't be in the urine. Okay, and if that is happening, then there's a problem somewhere. Okay, so it means that the glomerular is not functioning as it ought. Okay, but the major thing that we're looking at is the albumin to creatinine ratio. All right, this is a major marker for kidney damage. Albumin to creatinine ratio is a major marker for kidney damage, and it's important for us to know about this because this can help us determine whether there's kidney damage going on in a person and ultimately whether there's chronic kidney disease. Okay, so we've said that there are two ways of defining chronic kidney disease. There's that part that has to do with kidney function, and there's the part that has to do with kidney damage. Okay, either of the two, depending on the values you get, can determine whether chronic kidney disease, okay, is happening. All right. So there are also clearance tests. Clearance tests will be a major way of determining glomerular filtration rates. The kidney actually is supposed to filter about 120 mils of blood per minute. All right, to filter about 120 mils of blood per minute. Now, if the kidney can filter at this rate, it means that there's a dysfunction, it means there's a problem. Okay, so clearance of a substance is defined as the volume of plasma that is cleared of that substance in a unit time. All right. Now, ideally, it have been better to assess a patient based on the actual glomerular filtration rates of that individual. Okay, by running the test to see how well the kidney is filtering a known substance. But it is a very cumbersome kind of test to do because it has to be done in a 24-hour period in which a person has to be injected with a substance, okay, which the kidney alone can clear, all right, and is not reabsorbed or secreted. And then you take urine in a 24-hour period. As taking blood sample, you're taking the urine to measure the glomerular filtration rate of that substance. So, and this is not really practicable. Okay, it's not practicable, whether in research or in clinical practice. So what is now done is that an estimated GFR is calculated for each person to check this estimated glomerular filtration rate actually, it measures the actual glomerular filtration rate, okay? And that is what is used. It's easier to carry out. All you just need to do is to take the person's blood and then measure the serum creatinine, and then based on some other parameters, an estimated GFR can be reported, and that can also help to determine the functioning of the nephrons. So we're saying clearance tests can also be used to determine the kidney function, okay? And one of the clearance tests will be the glomerular filtration rate, okay? And I said that the measured glomerular filtration rate is difficult to carry out. And so an estimated glomerular filtration rate, okay, has been developed, which is a close estimate of the measured glomerular filtration rate for a particular person of age, of sex, and all that. Okay, we'll look at that a little more closely next. So there are different approaches to estimate kidney function. Remember, the reason why we're coming here is because we want to try and see how we can determine if a person actually has chronic kidney disease. Because one of the ways of defining chronic kidney disease is by assessing the kidney function, okay? And they know that the kidney function has a particular parameter, okay? And so if he falls below that, that person may have chronic kidney disease. So how do we measure that? And we just said, I just told you that to actually, the gold standard would have been to actually measure the person's glomerular filtration rate, but it is not very, very practicable, okay? In a clinical setting, it's not very convenient to do. And so different ways of estimating kidney function have been developed. Of course, the very familiar one is the Cockcroft-Gault estimate, okay, of creatinine clearance, okay? Now, this in many places is no longer used because newer equations have been developed, okay? So we have what these ones do is like they take the serum creatinine, all right, and then they compare it, okay? They factor in person's age, person's weight, height, sex, okay? And then they estimate the GFR for that person. Now these experiments were done for large pools of people, okay? And then they found that there was an equation which actually measures the actual glomerular filtration rate, okay? So instead of now measuring the actual glomerular filtration rate of a person in a 24-hour period, you know, they put it in that equation and they found that it tallied, all right? And so all you need to do now is to just get the person's serum creatinine and then impute it into the equations, and then you can have an estimated glomerular filtration rate, which is used to determine a person's kidney function. Like I said, the Cockcroft-Gault estimates, you know, of creatinine clearance was used for a very long time, but now we have more modern estimates, okay, which are judged to be better. So we have the modification of diet in renal disease, MDRD equation. Now this equation was derived from patients with chronic kidney disease, all right? And then we also now have the chronic kidney disease epidemiology study, all right? This includes patients or people who do not have chronic kidney disease and those who have chronic kidney disease, and has a very large pool of people of different races. Okay, so this seems to be a better estimate of creatinine clearance and is majorly used now. And the results are standardized, so much so that if you go to labs, they will return EGFR for you, okay? And you will see the EGFR placed there in the lab results, okay? And this is likely what has been used, okay? This equation is what has been used to estimate it. So what you need to look out for when a patient brings that result is the EGFR, and you know what the standard should be, and then you can tell whether the person has a problem with kidney function, okay? So these are the things that you look out for. MDRD or Ckd API, all right, which helps you to estimate the person's glomerular filtration rate. Okay, so we say normal serum creatinine. Okay, how do you know if it's normal? Does that really mean anything? Say the person has normal serum creatinine. Okay, or does it mean anything? Serum creatinine level is affected by muscle mass, age, gender, and race. Do you get that? So what may be normal may not actually be normal. Okay, because somebody that has very large muscle mass, for instance, okay, may have a higher than normal creatinine. That does not mean that the patient has a problem. Okay, then also somebody that has very little muscle mass, okay, and you will see that the person has normal creatinine, that may also be a problem because he doesn't even have enough of muscle mass to produce the required amount of creatinine, okay, that can show whether the kidney is not functioning. Okay, and then of course age too. As people age, okay, the kidney function also diminishes. Okay, gender and race, all these affect the creatinine clearance. So we have to be careful, okay, when you say somebody has normal serum creatinine. All right. So a so-called normal serum creatinine level of 0.6 to 1.2 milligram per DL may actually not be normal for most people because it does not account for muscle mass, age, gender, and race. And that is why the Cockcroft-Guilt equation is not really used now because that does not take into account of the body surface area. Okay, and so the newer equations, okay, the Ckd EPI, okay, takes into account the race, okay, whether you're a black person or whether you're Caucasian, all right, the age, gender, and then the mass of the person. All this will determine how close to the actual GFR, the estimate will be. That is why the eGFR is used, and it's the eGFR of either the MDRD or the Ckd EPI is now commonly used. Again, the Ckd EPI is standardized in all labs. So if you go to 2 different labs with the same serum creatinine and those other parameters, you're likely to get the same eGFR reported. Okay. All right. So I already talked about this. Okay. So let's move on. So here is the MDRD eGFR formula or equation. You see, it's a standardized serum creatinine, age, and then when it is female, it's African, American, all that is imputed. For the Ckd EPI 2, we also have different parameters imputed together with the serum creatinine, and then the equation returns an eGFR, which is very close to what would be if you had actually measured it. Okay, so the estimate is normalized to body surface area. So let's look at the eGFR values. Now, if a person has about greater or equal to 50 mils per milliliters per minute per 1.73 meters square, okay, of eGFR, the person is said to have a normal eGFR. Okay, yeah, of course, when you look at the stages of chronic kidney disease, you will see greater than 90 milliliters per minute per 1.73 meters square. But this generally is used as the cutoff, okay, for somebody that has chronic kidney disease. If it's less than this, they're considering that the person actually has a problem, okay. But you see, if it's an elderly person, very elderly person that has maybe like 55, okay, that doesn't necessarily mean that the person has chronic kidney disease because age, as we said before, your GFR declines with age. So if the person has eGFR of 15 to 59 milliliter per minute per 1.73 meters square, then the person actually probably has chronic kidney disease, okay? And if it's less than 15, then there's kidney failure already, okay? So this can be a marker for kidney function, okay, using the eGFR. And as pharmacists, we should know this, okay? So we know this to help check, okay, the diagnosis have been made by the physician to also help us to monitor the progress of the disease and the treatment of the patient, okay? So different stages of the chronic kidney disease, we see that Okay, so next, no, we talk about kidney function test. Okay, that's where the EGFR comes in handy to help us to gauge a person's kidney function. And then we talk about kidney damage, which is the other leg upon which the chronic kidney diagnosis or definition is based. Okay, now in most cases, the evidence of kidney damage is reflected in many different kinds of findings. Okay, but in most cases, it means increased urine albumin, increased urine albumin in most cases. All right, so whenever there's increase in urine albumin in a person, that's an indication that there's kidney damage going on. Remember the vascular tufts we talked about in glomeruli, okay, the semi-permeable membrane ordinarily should not allow that much large molecules to pass through. And so if it's passing through, it means that there's a dysfunction, there's a problem, there's damage going on. All right, and for it to be high, it means that so many nephrons are already affected. Okay, so the urine albumin is a marker for kidney damage. Okay, and that will help us as pharmacists to assess and monitor kidney damage. Okay, and then we also have to understand the urine albumin to creatinine ratio, which is actually a spot test, a spot check, a spot test to help to identify from the urine whether there's macro albuminuria, whether there's plenty of albumin in the urine. Okay, we need to understand that. Okay, so yeah, you have kidney function. This is what is the EGFR can be used to determine kidney function, and then kidney damage. We said if there is decreased GFR or not at all, and then you have either a pathological abnormality. Now, by this we mean, so for instance, somebody does a scan, okay, checking for something else, and then they find pathologies in the kidney. Like I said, kidney stones that can be revealed in a scan, in an ultrasound scan, okay. Then it could mean that the person is having kidney damage going on because there are pathological findings, okay, from the scan. All right, is it possible that they do a scan and they find that the person only has one kidney? Now, some persons actually born like that, just one kidney, with just one kidney, okay, and that can only be seen after a scan has been done, okay, and that will also mean that the person may eventually have a problem, okay, with kidney disease, and so an imaging can help us to determine kidney damage. And then again, like I mentioned before, markers of kidney damage will include albumin or protein in urine, also blood, you know, hematuria, blood in the urine too can also be a marker, all right? But most times what we use is the level of albumin in urine, okay, to determine kidney damage. So this factor, the urine albumin to creatinine ratio, all right, if it's more than 30 milligrams per gram, that is, if the ratio is more than 30 milligrams of albumin to a gram of creatinine, then we know that the person is having kidney damage, okay? So less than 3 milligram albumin per gram of creatinine or 30 milligram per day, okay, would mean that it's okay, right? So greater than 30 milligram per gram of albumin to creatinine is an indication, is a marker of kidney damage. So we need to note this, okay, to help us and gauge whether kidney damage is occurring in a patient. Now, you will see, next slide, you will see something like this, okay? Less than 30 milligrams per gram is normal. You will see 30 milligrams to 300 milligrams per gram of creatinine, right, as microalbuminuria. Now you're wondering how come 30 to 300 be micro and then more than 300 milligrams be macroalbuminuria. Now this is a spot test, okay, it's a urine spot test. Now when you get 1+, okay, this can indicate 1+, that's microalbuminuria, okay. When there's no plus, then you are probably at this level, okay. So that is what it's actually supposed to be, a continuum, okay, but this is how to determine the level of albumin in urine. Okay, so when you say somebody has microalbuminuria, it means that the albumin level is above 30 to 300 milligrams per gram. And then when it's more than 300 milligrams per gram, this person has macroalbuminuria, which means that, of course, there's evidence of kidney damage. Okay. Okay. So the urine albumin as a tool for screening, diagnosing, and treating CKD. So you must note that urine albumin is a marker for kidney damage. Albumin is the predominant protein in the urine of people with kidney disease. Okay, so increased urine albumin generally reflects glomerular injury. Okay, so yeah, you can use this to monitor therapy. All right. Now, it's also an important prognostic marker, especially in diabetes. Okay. And then it can also be a tool for patient education and self-management, because the patient can actually do the dipstick test by himself, and what the results show can help the patient know how he's progressing with his management. Okay. So abnormal urine albumin result is often the earliest marker for kidney disease complicating diabetes. Somebody that has diabetes and is going to have large amounts of albumin in urine will also indicate to you that chronic kidney disease is setting in. Okay, so as pharmacists, we need to understand this. Okay. Okay, so now let's briefly talk about the role of the pharmacist in CKD. All right, let's talk about the role. So now that with the things we've discussed right now, you can check that the diagnosis is correct. So if a doctor makes a diagnosis for a patient, all right, you can confirm that, you can check that, okay, before drugs are prescribed, because you need to know whether the drugs are indicated, right? There has to be an indication for every drug. So if the doctor is prescribing drugs, okay, that indicate that the patient has chronic kidney disease and they're managing that, you can check to be sure, okay, based on what we just discussed, the EGFR and then the Uacr, all right, and then the other parameters that we've looked at. You can also use these values to monitor progression of the disease, okay, and then you can implement appropriate therapy to slow progression. Now, people that have diabetes, hypertension, cardiovascular disease, and stuff like that, obesity, like we said before, these are risk factors. And so even when the patients do not have CKD yet, or don't have kidney disease yet, you know, we want to begin to prepare, to plan to prevent those diseases, or when they have CKD, to slow down the progression. And that is what pharmacists can do. And with what we have discussed right now, you know, some of the drugs that come in handy, okay? And of course, with the other tools that are available, you can tell what drugs, okay, should not be given to a patient that can compromise the kidney, all right? And even with diet too, okay? And you've noticed that, for instance, in hypertension, you talk about the DASH diet, but it's been said that the DASH diet may have too much of potassium, okay, and phosphorus for a patient that has chronic kidney disease or at risk of chronic kidney disease. So the person has hypertension and CKD, for instance, you know, that DASH diet that we talk about for hypertension may have to be modified, okay, to take into account the fact that CKD, okay, is complicating the hypertension, all right? So that is very important. So how do we monitor progression? We monitor progression, like we said before, through EGFR and Uacr, okay? Another role of the pharmacist is to screen for CKD complications, okay? You know, the complications of CKD, mention them based on the function of the kidney: anemia, all right, bone weakness, fluid retention, okay, gout. So there's gout, that means there's high level of uric acid in the blood, okay? Yeah, heart disease, all this, high blood pressure, hyperkalemia, and all that. All these are things that you screen, okay, when the person has chronic kidney disease, okay, or if the person has not been diagnosed yet and has any of the other risk factors, the other diseases. You need to notice all these things. You know, for instance, anemia, that there's really no cause. Person is not sick, is not hospitalized, is eating well, but there's this anemia is persistent, it's possible that erythropoietin is not being produced because the kidney is beginning to decline in its function. All right. So that's what pharmacists can do in that regard. Okay. Then also, pharmacists also have to play a role in managing the shared CVD and CKD risk. Okay, diabetes, hypertension, obesity, lipid abnormalities, and smoking. All right, these risk factors, these things have to be considered. Okay, in this kind of patients that have both CVD and CKD risk, you need to counsel them. Now, usually we counsel patients regarding hypertension, diabetes, obesity, and lipid abnormalities, but most times we don't factor in chronic kidney disease. Okay, but you see, many people who have diabetes and hypertension actually end up having chronic kidney disease. And so we need to begin to factor that in as well and counsel them as well. Okay, now, patients that have acute kidney injury, okay, for instance, we need to understand the role of drugs, particularly NSAIDs. Now, I didn't have time to discuss the role of NSAIDs. NSAIDs can actually cause kidney damage itself. Okay, so we must be careful in the way these drugs are used. And now, particularly the way people are misusing NSAIDs, and so many persons are actually having kidney disease. And that's because we do not counsel them, and we should be careful how we recommend these drugs for patients. Okay, the pharmacist should also know when to refer to a dietitian, because people that have chronic kidney disease should not eat the same kind of meals that everybody eats. Okay, they have to reduce certain meals. For instance, meals that contain high amount of potassium, phosphorus, okay, and then protein, high protein diets should be limited. Okay, and then we should also learn to educate patients about CKD. All right, both the ones that do not have it and those who have it. We need to always talk about chronic kidney disease and how to prevent it when they don't have it yet or at risk of chronic kidney disease. And those that have chronic kidney disease, we need to also educate them on how to cope with the disease and to reduce or prevent the progression of the disease. So that's the much you can take for today. I hope we have been able to learn a thing or two from this discussion. I'd like to stop here. Thank you very much.
Thank you, sir. Thank you, Prof.
Thank you so much, Prof.
Thank you, Prof.
Thank you very, very much. In fact, this is another lecture that I thank God I did not actually miss it. Before I call on people to make comments, observation, and ask questions, I want to recognize two of our own and my teacher, the professor of the professors, and the doctor of the doctors. Professor Azukal Opara, you are welcome, sir. Thanks for always being with us. I also want to recognize the DPS of Osun State, Pharmacist Fashekpe. You are welcome. We thank you for being with us. I do not intend to give another lecture. However, I sure that we really enjoyed what we have listened to. And I just want to say that the lectures were actually dampened on some areas. The anatomical design of the kidney were thoroughly dealt with. The physiological activity were also dealt with, and the pharmacological effect of drugs on the kidney were also done with. And the lecturer was able to tell us how to identify the decline in the major functions of the kidney, which involved the filtration, the excretion effect, the metabolic activity, the electrolyte balance effect, and the homeostatic and the endocrine effect of the kidney. And he eventually gave us how to manage as pharmacists. How can we manage the two major functions the decline of the kidney, which has to do with the filtration and as well as the kidney damage. The effect of the drugs on the kidney we are also thoroughly looked into, especially the NSAID, as you have said, when there's a combination of NSAID, ACI, and diuretics, and then the CKD risk diseases, and what we should do as pharmacists in terms of counseling of those people with comorbidity in relation to the compromise of their kidney disease. Like I said, I actually do not intend to do another lecture. So before I call on the questions, I have been seeing the national chairman's hand being raised up. So I want to recognize our chairman, Dr. Joseph Madu. You have the floor, sir.
Right. Good evening, everyone. Please, am I audible enough?
Yes, sir. You are.
Let me use this opportunity to thank every participant at this meeting tonight. I can see that the attendance is above 80, and that is good. It's true that you said the moderator, Dr. Spielman, said that has been seeing my hand. Actually, I'm so enthusiastic to speak. A lecture being presented by Professor Odili, who was a lecturer in University of Benin when I was doing FAMD update program over 15 years ago. But before I move on, let me first of all, once again, appreciate the presence of the CPAM Board Chairman, Professor Azuka Okpara, and also the PSN National Unofficial Member, Dr. Uacr. We appreciate all of you and every other participants at this meeting. And most important to our guest tonight, my lecturer, my leader, Professor Valentine Odili. Very nice man. I've always about him wherever I go and talk about my former lecturers. So I want to say thank you once again for being here. I know that if we are to pay, we cannot pay for this lecture. And this lecture is one that I believe that most members of SPAN will like to listen to again the video. And thank God we have the SPAN YouTube channel. So it will be there, and from anywhere in the world, anybody can access this lecture. Personally, myself, I know I would like to go and listen to the lecture again. Of my anatomy lectures during my BFAM days. You spoke very well, while the right kidney is slightly below the left kidney level or the line. We so appreciate this is something, if we are to pay an honorarium, we cannot pay much. We pay you for this. If one doesn't have the funds. But let me say this at this night also, as I was listening, I was in the nephrology pharmacist group, which is a kind of a group that is bringing up specialists in clinical pharmacy areas. And I can see that kidney, the issues about kidney, still all that concerns nephrology. And please, I know that we shall still be coming back to you. We believe you can help build the nephrology group of Nigeria. It also reminds me of a book by Dr. Odutola, Dr. Adedola. He's so rest in peace. I can see the way Professor Odili is talking about markers and the rest of them. And I want to speak to Dr. Odili, Professor Odili this night, and Professor Opagato and some other academics with us tonight, some academics who are members of NAP. Actually, I know that clinical pharmacy itself came to Nigeria through NAP, through our academics. I know that Professor this book, Routine Interpretation of Clinical and clinical laboratory values. Yes, rapid in clinical laboratory values. And I believe that even though Dr. Dutola is not alive today, the professor will look at his book and see if they can write it. And I believe it will be very useful to pharmacists. Because when you are telling us, for instance, if we see albumin level getting high, then from maybe urine analysis or whatever, we begin to suspect kidney damage. That means that if we have foods like this, we can always grow. Because I see many persons in Japan asking me what and what or what will be recommended. So I would recommend that our academics help us that in due course. Once again, thank you so much. I want to thank everyone. And thank you so much, the moderator, for giving me the opportunity to speak. God bless you. God bless pharmacy in Nigeria. Thank you very much.
Thank you, sir. You have spoken the mind of the millions of the pharmacists tonight. And just like you have said, we cannot thank our presenter enough for the wonderful presentation he has given. He has reignited all our knowledge of the physiology, anatomy, pharmacology, and the clinical pharmacy in particular. So I do, because I know the time is well spent, so and I can see the hand of pharmacist Omolola Mwakuma. Can you please make your comment or ask your question? Unmute yourself and then ask your question.
Okay. Thank you so much. Good evening, folks.
Good evening.
The lecture was useful. In fact, you took your time to dissect it and give us what we need. Yeah, I want to ask a question. You said something about hypertension, diabetes, they can be predisposed to kidney failure or kidney issues. And in a situation where someone has hypertension or CHF, you know, there'll be issues of fluid retention, and the person also has a kidney problem. How do you balance the use of diuretics? Which ones are safe to use when someone has a kidney problem, has hypertension, and you're also trying to manage retention with the patient?
All right, thank you very much. I didn't quite get your question, but let me say, you're asking how do you manage a patient that has hypertension, diabetes mellitus, and what else? Kidney dysfunction, kidney disease,
yes,
right?
There's fluid retention, and you know you mentioned that most of these diuretics walk through the kidneys, and so, you know, they are excreted through the kidneys, and some are not good for patients with kidney problems.
Yes. Okay, so that's where the pharmacist comes in. You need to try and balance the use of medications, okay, to get the exact outcome that you want. Okay. Now, when I talk about the kidney, okay, it depends on how bad it is. For instance, somebody who is actually end-stage renal disease and is on dialysis, there's no fear, there's no need. You can actually use whatever it is you want to use. You get that, because it's going to go on dialysis, right? But it's the ones that, okay, you're afraid, you want to preserve the amount of renal function that the person has. Okay, so you now choose the particular diuretic that you will use. Okay, and then what actually you're supposed to do is this. Depending on the values that you have in the blood, you're going to have to be running tests to monitor, okay, the amount of potassium, for instance, okay, which is increasing. All right, you have to determine the kind of diuretic that you will use so that the potassium does not go so high. Do you get that? So also for people that have hypertension, that generally we use ACEIs and ARBs, okay, come in very handy, right? People that have hypertension, diabetes, and all that stuff, okay? Particularly if the person has hypertension, ACEI will come in handy because it will protect the kidneys, okay, when they have DM and maybe kidney comorbid states. Okay, but again, even that too is not all kinds of patients that you can give ACEIs. those patients that have bilateral kidney vascular stenosis, all right, you cannot use ACIs for them. You get that? Because once you use ACIs, they go into renal failure immediately because the body is already compensating, okay, but trying to maintain filtration pressure. And once you give ACIs or you give ARDs, okay, what happens immediately is that the person goes into renal failure. So for those kind of patients, once they have bilateral renal vessel stenosis, you do not give ACIs. Do you get that? So actually, it's a delicate matter, actually, and that's where pharmacists come in. You need to know the degree of renal failure or renal disease, okay? And then the drugs which will not increase, okay, the progression of the disease. But if you're going to give it for a short time too, if it's needed, you can do that. Okay, you can do that, but while you're monitoring, and that's why we're talking about dose reduction. All right, we're talking about using drugs that are not metabolized in the kidney as much as possible. Okay, so these are the things that we need to tweak. All right, now just that this lecture is not focusing on this aspect. You know, what I've used, giving you medications, examples of these kind of situations, and the drugs that you're going to use. Okay.
Thank you so much, sir.
Yeah, thank you, Pharmacist Omolola, and thank you, Prof, for the response. Is there any other person that has any observation or questions or contributions before we... Yes, Prof, there is a question that someone is asking that how can UACR test be done? That you should please explain how UACR test is being done.
Okay, the UACR test actually is a urine albumin to creatinine ratio. It's a dipstick test, right? A dipstick is like, you know, you just get the urine, okay, and then the dipstick is put in there, and you see, you can check with the back of the container based on the color. You get plus, 1 plus, and all that stuff. Do you get that? So when you have 2 pluses, for instance, it tells you the amount of albumin compared to creatinine in the person's blood, okay, and that gives you an indication. Do you understand that? It's a dipstick test. Do you get that?
Okay, sir.
Yes.
Another question on the chat is someone is asking that there is an investigation going on the renal risk reduction, and the R3 on the HIV patients in the facility is being done, but then they had challenges on the laboratory results that is giving the outrageous UACR values, and then he want to know whether there can be standardization and so that the functions can actually be curtailed.
Yeah, you know, the UACR test is a biochemical test. All right. So what you need to do, I don't know the kind of the particular test they're using, okay, is to probably look for a different one and compare. You get that? It's actually just checking what it does is that, you know, ordinarily you're supposed to do a 24-hour test, okay? Check the amount of albumin that is secreted or that is poured out in a 24-hour period, okay? But that is very cumbersome. And so because we know that about 1 gram of creatinine is secreted or is filtered in 24 hours, then whatever amount of albumin, all right, is found in a spot test compared to creatinine will tell you the amount of albumin that you will have in 24 hours. So for instance, if the amount of albumin to creatinine ratio is like 2, that means you have twice of albumin compared to creatinine in 24 hours. That's what is used Okay, that's what that tells you. So instead of doing it for a 24-hour period, you just take that particular spot test and compare albumin that you see and then the creatinine that you see at that particular moment, and gives you a ratio, and that tells you what would have been in 24 hours. And so if it's more than 30 milligrams per gram of creatinine, then we say that the person has microalbuminuria. Okay, if it's 30 to 300 is micro. If it's more than 300, it is macro. Okay, so when you get about a plus, 1 plus, you say okay, it's micro. When you have 2 pluses and like that, you say it's increasing. Okay, and that means there's albumin in the blood, in the urine, which is indicative of kidney damage. So it's actually for them to try maybe a different strip, a different deep stick, and see whether it conforms.
Thank you, sir. There is a question as regards the people of blood group B, that there is a statement that they normally have kidney failure. Is it true? Or do you have any information? People with blood group B.
I don't have blood group B or genotype. What do you mean?
Yes. No, I don't think it's genotype. It's a group B.
Oh, B. Okay, B. Yeah. No, I don't have that information. I'll have to check that. I wouldn't know that. Yes, I've not seen that. I don't know.
Thank you, sir. If there are no other information or question, I think one thing that we must take home tonight as pharmacists, especially as clinical pharmacists, is that we should be conversant with the activity of our drugs as regards the kidney integrity, whether in terms of the kidney malfunctioning or kidney damage or the drug-drug interaction that we use, especially the commonest drugs. We've just said about the use of the ACI with diuretics along with the NSAID. So it is one of the duties of us as pharmacists to know what is likely to happen when there is combination of these drugs. So drug-drug interaction as regard our commodities is essential for our patients, especially when they have comorbidities. So if there are no other questions, I want to call on someone to give us a vote of thanks and as well give us a closing prayer. I don't know whether one of my sisters, a very close and old friend, Pharmacist Awa Sadiq Additional, is she still online? She can unmute herself and give us a closing prayer as well as a vote of thanks to our presenter. Additional, are you there?
Yeah, yes, I am.
Thank God, I can hear your voice now. After so many years.
Thank you so much for a very wonderful lecture. In fact, it's like I've never had a lecture on this before. It's very full. We're very grateful, and we hope you'll be able to give us something again sometimes in the future when asked. Thank you so much on behalf of everybody from CPAN. We wish to thank you. We pray everybody, we pray to God to keep us all together and give us good health and bless Nigeria and make Nigeria a better place for us all. Thank you so much. And good night.
Amen. Thank you. Thank you, everyone. Thank you for coming. Thank you for staying till the end. So we hope to meet again next Friday by God's grace. And thank you, Shema, for staying with us till the end. So good night, everyone.
Good night, Professor Dili. Thank you, sir.
And for me, yeah, good morning.
Thank you very much. Good morning.
Good morning from Uganda.
Thank everybody.
Wow.
Good night, everyone.
Good night.